In this video, I will cover an entrapment of the median nerve, a main culprit of carpal tunnel syndrome and wrist pain. Expect to learn the function of the median nerve, where do entrapments occur, clinical presentations with an entrapment, and how to effectively find and treat the entrapment. For those of you that don't know me, my name is Dr. Matt Maggio. I am a soft tissue injury treatment expert, specifically for neck, shoulder, sciatica, and hip pain. My focus is on finding and fixing adhesion and reducing inflammation from chronic injuries without the use of drugs, injections, or surgeries, which does lead to a significant increase in overall functioning, flexibility, and long lasting pain relief. I'm also the creator of the soft tissue treatment revolution, where we teach overworked massage therapists a new treatment system that will allow you to cut your treatment times by at least 50% so you can stay healthy, avoid that dreaded burnout, and help a hell of a lot more people get out of pain. All right, so median nerve entrapment breakdown, function, entrapment sites, clinical presentations, and proper treatment. Let's get right in and learn something fun today. So first off, what is the function of the median nerve? The first is its motor function, which simply means it helps move several different muscles in the forearm that control the motion, which is called flexion, and deep into the hand as well. It also does some sensory functions. Essentially, it helps give the brain data about what is felt around the area, especially what is happening on the skin of the surface. It does some sensory part of the palm as well, the second to the fourth fingers as well, does some sensory in there as well. So it is a combo nerve. It does both motor and sensory function. A lot of jobs there. So where does it get stuck? So let's just start with why nerve entrapments happen in the first place. Talk about this all the time. Over time, the muscles get overworked. They don't get enough blood flow. They don't get enough oxygen. They create a thing called hypoxia, which basically is not enough oxygen. So the body thinks there's an injury there, and it starts to lay down these immature collagen fibers that I call adhesion. They're also called scar tissue. Over time, that gets bigger and bigger. Now, nerves are built with about 15% of extra slack to get where they need to go, like a rubber band. And eventually, as that adhesion builds up, it gets stuck to the nerve, creates a nerve entrapment. So the median nerve has a long way to go, starts all the way up at the base of the neck and goes all the way down to the carpal tunnel. So the first area where it can get caught is anywhere between the C6 and T1 nerve roots between the scalenes. It could get caught in the anterior to middle scalenes or the middle to the posterior scalenes as well. That's a very common site that I see on the lateral part of the neck. It also can get caught on the brachial cord, specifically at the subscap. So on the front part there of the armpit is where the brachial cords come in. Median nerve is kind of dead center. It's above it is going to be the radial nerve, and below it is going to be the ulnar nerve. It can get caught in either one of those areas. Next area it does get caught is down in the medial part of the forearm called the pronator teres. In a lot of cadavers and anatomy breakdown, sometimes the median nerve actually pierces right through the pronator teres. Sometimes it goes under, sometimes it goes over top. Just depends on the person and how they're laid out. The next area where it can get caught is really deep in the forearm in the flexor digitorum superficialis. It's one of the main flexors of the forearm. It can get caught in there as well. And then the last area where an entrapment can occur is right in the palm, in the carpal tunnel itself. So there's a lot of areas where this nerve can get caught. So why does it get stuck? Why does it get caught? Talked about it before. Poor and sustained posture. That's when scar tissue forms and adhesion forms. Maybe repetitive use. People doing something with their job, one-sided, doing it a lot more. Definitely an injury or trauma, and then possibly some issues from past surgeries when they go in there. Maybe someone broke an arm, or they had some type of surgery up their chain into their shoulder and their neck as well. They can nick some of those nerves, cause some issues in there as well. But mostly I'm going to see it from poor and sustained posture, indefinitely repetitive use. And, there will be some injury and trauma in there as well, but more likely just where it kind of comes out of nowhere. There's no real mechanism of injury and it starts to build up more and more. And then the client presents with that clinical presentation of carpal tunnel syndrome. So common injuries associated with an entrapment, one is just going to be the clinical signs. Whenever there's a nerve entrapment, they have a hallmark sign of what they're presenting with. They're going to be numb, aching, burning, and tension. Those are things that I'm always asking when I'm taking a thorough and in-depth history. I'm like, what does that pain feel like? They're like, Sometimes clients don't want to give you all the information, but the information really helps you figure out exactly what's going on so you know if you're dealing with a nerve entrapment. Next one is just carpal tunnel syndrome. I talk about this all the time. Anything with syndrome in it doesn't really tell us anything. It's kind of a code word for they have no clue as to what's going on. You need to have a tissue specific diagnosis every single time so you know exactly where the problem is and where it is so you can actually go in and fix it. Because if you don't know where it is in the first place, you sure as hell can't fix it. And then also, you're just going to possibly see some pain, some numbness, or weakness in the forearm or the wrist or the fingers themselves when there's an entrapment involved. So, how to effectively treat it? So, there's a couple things that you really want to understand here. Trying to understand, is it actually coming from down in the wrist in the carpal tunnel itself, or is it coming from somewhere higher up the chain, in through the elbow, in through the brachial cords, up through the neck as well? One thing that I do when I do decide if I want to start higher up is, was there a history of neck or shoulder trauma? And a lot of times, when that is the case, more than likely, if they're getting distal symptoms into the carpal tunnel distribution, I'm usually thinking the problem is somewhere higher up. And when do I start lower down? When there's no actual true mechanism of an injury. Maybe they just come in with carpal tunnel like syndrome and they don't have any other history points that point to elbow or wrist or anything like that. I do like to start further down and then work my way up. So I'm going to check everything as I go through when I'm checking a nerve entrapment, knowing where it goes. And like I said, the nerve entrapment for the median nerve can span a lot of area. So first, I'm going to start up at the nerve roots at the scalenes, and I'm going to get in there and do some manual work. It implies proper depth and tension. We hold that nerve down, and then we have them go through a full range of motion that frees up that nerve entrapment on those scalenes. Next thing we're going to do is treat it at the brachial cords at the subscap, where they're laying down, and we're going in there and getting some tension and depth on that. Freeing that up should not be excruciating, shouldn't hurt like hell. If it is, you're just jamming that nerve in there and you just don't like your clients and you want to hurt them, which we don't want to do. We want to make sure it's an effective treatment and we're not really beating the crap out of the area. Then I will go in and do some work on the pronator teres itself. With this one, I do like to use an instrument as I go in there with like a round edge in there that can really break down some of that entrapment in there as well. Then I will do a little bit of manual work if it's a little bit deeper. Then the next area is going to be in the flexor digitorum superficialis. That one I do like to use my hands strictly for because the instrument can't get in there because it's too thick and it's too deep. Really getting proper depth and tension into that area and breaking that down. And then the last area I will treat is down in the carpal tunnel itself. And I like to do instrument work in there as well. So, really deciding where I'm going to start. I don't treat it all in one visit. If I have a history of neck, shoulder, elbow stuff, I'm going to work higher up. If I don't have that history, I'm going to start down low. So, a lot of people will get carpal tunnel release, but it's not actually the problem. It's actually coming from somewhere else. So, the key is doing that thorough history, asking the right questions, doing a functional evaluation, not being in such a rush to just want to jump right into treatment and just being a technique person. Instead, be more of a clinician. I want you to be a clinician first and a technician second so you can apply the exact treatment that needs it every time, get predictable results, real results that are going to help your clients, help you get a good result, and continue to solve problems that other people aren't, and also keeping people the hell away from pain pills, injections, and surgeries, which only make things worse. That's all I got for you in the video. I appreciate you watching. You can do me a solid and share this with other providers out there looking to do excellent work and want to fix problems. Thanks for watching, and I'll see you on the next one. Bye.